The program has been running. Over 30 people are committed to it. It's only a challenge today that the timing is after office hours, and the majority of us said that they planned to use the internet in the office because internet is quite expensive in Uganda. So some of us want to be able to attend, partly because of that. So others will be traveling home from places of work. So as you all know, Carrie, maybe next time the meeting will be arranged for evening hours, which will be your evening hours. It may be better that way next time.
Not a problem. We will, we will adjust as needed. Yeah. So that being said, welcome everyone. I'm Carrie Hopkins-Isles. I'm the Deputy Director for ICU DDR, and I'm so glad to have you here as part of our Uganda group. And I know you're working hard on your sessions so far, the walkthrough. Thank you for the feedback when we've had challenges, like one of the videos I know was recorded or was put in 2 sections, and we put the right one up for that. So thank you for letting me know those challenges. And I see the active conversations in the WhatsApp group and all of the good work that people are doing. So thank you. I know it's a lot on top of your full-time jobs and your lives and everything else. And so the goal for today is that we have our excellent colleagues, Dr. Moses Adu and Dr. Igor Kutsanok and myself, and we're here to answer any questions you have, facilitate any kind of discussion. I have let the doctors know some of the things that I saw from your post-tests. However, that's just sort of some guidelines for them, some ideas. If there are other things that you would prefer to discuss regarding the first 2 modules, which are physiology and pharmacology for addiction professionals and treatment for substance use disorders, the continuum of care for addiction professionals, we are here to talk about any of that. So let me just open the floor for any questions or comments, either on how it's going so far or questions you have, anything of that nature. And so I'll give you a minute if you want to unmute yourself and share any questions or comments.
Can I start?
Please.
Yeah, this is Ezra. One of the challenges I had as I supported the team is that the manual with the guidelines of how to use the health.com page or the manual, it was too brief. It needed more details with screenshots that are clear and detailed from step by step, so that people can pick that manual and use it without asking every other step. So some people would get to the website and get lost.
So you're referring to this, right? Your trainer manual?
No, the guidelines that you sent, as to how one could use the website.
Oh, okay. So you're talking about the learning management system, and you needed more information on how to use that.
Yes. We need to have it more detailed the next time.
Okay. Thank you. What about the training that Kim provided during our initial kickoff meeting? Did that assist?
Yeah, it did in many ways, but still, not all of the participants attended.
Okay.
But still, when up to this morning, I still got asked questions about how do I get post-test? Why are the pre-test same questions as post-test?
Sure.
Yeah, things like that. They would get back to the website and have trouble finding some of these things that may
Okay.
appear simple to but they don't appear simple to everyone.
Right, absolutely. Okay, thank you. I made a note of that. Okay. Any questions directly related to the courses that you've completed so far, number 1 or 2? Okay. Well, if that is the case, then I'm going to ask my good colleagues and friends, doctors here, to review some of the things that we had become aware of might be challenges based on your post-test. And in case anyone does have any question on that, the way it's set up is you take the pre-test with the idea that you won't have the knowledge base necessarily, and it gives us an idea of a foundation. And then you take the course and hopefully your knowledge, improves exponentially. And then if in the post-test you're still having challenges with some questions, which is what I observed, then we can review those and help you with it. So, Igor, do you mind if I put you on the spot? Do you want to jump into any of the topics that I mentioned were challenges?
No, I don't mind. Just let's make sure that the questions that you put out of are relevant for people who are participating now. Are those things that they really want to know? Because it might be a question posed by somebody else who is not here.
It's true, but they have to talk then.
Oh yeah, they do. So, folks, it's let's use our time and your time wisely. Based on this course and your pre and post test, what difficulties have you encountered in answering the tests? What are the things that are not clear to you and you would like to clarify? Because this is what we are here for. I hope nobody's in a coma.
This is Goreka. I have a question.
Go ahead.
One of the challenges I found was in looking at the signs and symptoms and things that people go through as they recover or as they go through withdrawal. There seem to be so many symptoms. Some are similar. In working in actual practice, would one be required to actually memorize everything, or do you end up working with a particular group and you just pick up and get to know them? That was a bit, so I debated between trying to memorize them or just understanding them and then maybe going back to them later. So I'd like some clarification on that one.
And that's a really good question. I'm glad you asked. And before I let people who know a lot more about it than me discuss, I will just say that there's what you probably need to do in real practice. And then I'll just remind Igor and Moses, there's also the fact that a lot of people here would like to take their ICAP exams. So, there might be what you need to know in practice and then what you need to know for exams.
Yeah.
Which aren't necessarily the same thing, right?
Moses, would you like to address this question about the withdrawal symptoms?
Oh, you're muted, Moses.
Okay. Yes. Well, you don't need to. I want to start, this way. Most of some of the psychoactive substances actually act on similar neurotransmitters, and because they act on similar neurotransmitters, and then they belong to the same maybe class of drugs, you find that some of the effects are actually similar, and then the brain has a very narrow range in which it can actually express itself. So you find a lot of symptoms overlapping, a lot of overlapping of symptoms which you clearly actually identify. So for you to know which drug is involved, usually when they come, you assess them, you can do some tests to see what substances they have taken. But if you are working in a resource constrained environment like mine, whereby in some places you may not even get the test kits to test for some of these drugs in the system, you now depend on your clinical assessment and judgment, and that will depend on how much information you're able to get, and then the knowledge of the psychoactive substances that the client would have used. And you also have to know, for instance, the duration of last intake, and then the pharmacology of the psychoactive substance will really help you to know, okay, if you took it maybe 4-6 hours ago, and now the patient is presenting with withdrawal symptoms. Now it's not up to me to think of what drug would the client have taken. If, for instance, I can do some tests, then I look at, is it a stimulant, is it a depressant, is it an opioid, or whatever. Then I look at which, the symptom pattern, which drug it actually fits. That will guide me to know which drug I'm actually suspecting. But if you're able, the client is able to talk to you, then it's easier for you to actually detect which psychoactive substance the client is withdrawing from, and that will help you to be able to tackle, the withdrawal symptoms. So duration of last intake, when and then psychology of the drugs will really get you into knowing what to do and what to do. Because sometimes, for instance, in my place, there will be some patients who will not cooperate with you. What is, and you have the test kits. So what guides the judgment is the addiction and the classes, the pharmacology, and then you estimate the last duration of intake. That will guide you into helping the client. You don't need to memorize. If you've been working, it's easier for you to actually detect. But the other problem is that they may take a combination of substances. For instance, they may take a stimulant, and then they'll take a depressant. Some of my clients will take cocaine, and then it gives them the high, and then they say they are taking something like heroin to step down. So you find, the symptoms are modeled up, and they have to know which one they're likely to be withdrawing from, and which symptoms are actually presenting. Can you tease out the symptoms for heroin or from cocaine, or even if they take together with things like alcohol? So the symptom, the picture is modeled up. So it's up to you now to see which one requires more attention at that time, and then you'll be able to help. I don't know, maybe Dr. Igor can give more light to it.
Yes, thank you. Everything you said is accurate, actually. Here's a couple of thoughts from me to maybe make your life a little bit easier. Withdrawal symptoms is a set of phenomena, sensations that people go through when they try to stop using substances. Almost always, withdrawal symptoms are acute, meaning they start rapidly and they last relatively short time. With a very few exceptions, they're so-called long-lasting withdrawal symptoms, and typically they're mood swings, impulsivity, and insomnia. Insomnia is probably one of the longest lasting. So let's put these three aside for now. Let's talk about the acute withdrawal symptoms. Very briefly, folks. I don't know, you guys are young and you remember things. There are thousands of psychoactive substances that people use, and there is no way I can remember what the withdrawal will be like from all of these substances, because there are thousands. You may be younger and smarter, you can do it, I can't. The good news, though, I don't have to. And here is why. As long as I know which class of substances this particular drug belongs to, and there are 7 to 8 classes, I will be very accurate in my prediction what the intoxication will look like and what the withdrawal will look like. So I don't really need to remember all this, every substance in the world. I need to know which class of drugs this particular substance belongs to. And here is a big secret for you. This is, folks, something that you have never heard before, and don't tell anyone. Okay, this is the secret. This is my secret I will share with you before Christmas. The clinical picture of a withdrawal is just the opposite to the clinical picture of intoxication.
Mm.
And this is why it's so important for you to learn neurophysiology and neuropharmacology of different substances. Because if you know what intoxication looks like, you will be probably 100% accurate in your description of what the withdrawal will look like, because it will be just the opposite. Let me give you an example. What intoxication with amphetamines look like? What do people experience when they're intoxicated with amphetamines? Tell me. Lots of energy. There is no need to sleep. There is no need to eat. Typically, euphoria with some irritability. Grandiose thoughts of power. So these are typical sensations when people are intoxicated with stimulants, amphetamine type substances. A lot of energy, no sleep, no eating. Generally speaking, euphoric and active mood, massive, rapid activation. Now, when you know that, and I'm sure you do know that this is what intoxication looks like. Now, you guys tell me what the withdrawal will look like. Just the opposite. What the withdrawal will be like. Tell me. Get out of your coma and tell me. Gurika.
Okay, see, yes.
You asked the question. Now, tell me what the withdrawal from amphetamines will look like based on what we know the intoxicating. Go ahead. Yeah, that would be helpful. Okay, does anybody want to give it a shot?
So from what you said, there would be very low energy,
Right.
hungry,
Exactly.
very high appetite.
Exactly.
And maybe very negative feelings about themselves.
Exactly. And about other people too. So people will get paranoid.
Mm-hmm.
Yeah.
Other people are plotting against me.
Mm-hmm.
You're absolutely right. So that's exactly the opposite to intoxication. No energy, extreme fatigue. People will crash and sleep for 24 to 48 hours. They will be extremely hungry. They will need sugar, and they will feel craving for sugar, and they will be very paranoid. And these are people who are not going to play nicely with you. That's it. Okay? You got it? Do you still have questions about withdrawal? The one thing that I want to tell you might be helpful. Some of the withdrawals look very dramatic, and people are really sick. People are really feel like they're dying. Very few withdrawals actually are life-threatening. For instance, people withdrawing from opioids, from heroin, they feel like crap. They feel like they're going to die every minute. It is highly unlikely, very unlikely to die from heroin withdrawal. People who are withdrawing from brain depressants like alcohol, benzodiazepines, and barbiturates, these are the life-threatening withdrawals. These are the withdrawals that you really want to pay attention to this person and keep the person under control for a couple of days, because the typical reason people are dying during the withdrawal from depressants are epileptical seizures. Okay, so these are probably the only withdrawal that is life-threatening and you need to pay attention to. And the last thing I want to tell you is something that might be helpful for your practice. You can tell me, okay, smart guy, this all sounds very nice, but how many people use just one substance? Most people use more than one substance: alcohol, meth, and cannabis, or heroin, alcohol, and something else. So in that case, how can we tell which substance is responsible for this particular withdrawal? That would be a real mess. So here's what might help. Get a piece of paper like this, and get a pen like this, and write down every substance that the person is using, or every substance that you know the person is using, based on the test or based on the history. Open the manual and pick the one that has the longest half elimination time, meaning the substance that stays in the system the longest. This will be the substance most likely responsible for this withdrawal. You got it? It's simple.
All right. So, couple things. Some people were answering your question in the chat, saying low energy, sleepy, hungry, irritated. There's also a question from Gladys. I need a clarification about alcohol being classified in downers or depressants, and yet to some people it's a stimulant.
Alcohol is never a stimulant. You may feel the sense of initial stimulation before you will get goofy and very sleepy and then comatose and eventually die. Alcohol, the reason different substances are classified as depressants or stimulants is not how it makes you feel, but the main criteria is what neurotransmission pathway this substance actually affects the most.
Yeah.
Alcohol and benzodiazepines mostly, almost exclusively, affect the GABA, gamma aminobutyric acid neurotransmission pathway. GABA is the main inhibitory neurotransmitter. In other words, the more active the GABA, the more comatose and sleepy you will be. So alcohol, as well as benzodiazepines and barbiturates, are major depressants because they affect the inhibitory neurotransmission pathway. Did I answer your question? Did I answer your question? Okay, then I don't know if I answered your question. I guess I did.
I don't know either.
And the initial euphoria you get from alcohol is by actually depression. It depresses your system. Once the inhibitions are not there, you feel that initial phase of maybe of euphoria, but it's a calm one. You are not so energetic like you find in stimulants when you take alcohol. But soon after that, you know is the depressing effect you have with alcohol. As I said, you become sleepy. You can even go into coma, and from that, some people can even die from it. Actually, not a stimulant because it acts on the GABA receptors. I have that problem with my people too. They ask me the similar question, say, but why do you say alcohol is a depressant? When we take it to get high, and do so many things. I say, well, how long do you remain high when you take it? And when you take it and you get high, are you as energetic as somebody who takes cocaine or amphetamine? They said no. I said yes, because the neurotransmitters not differ. So eventually you go into a depressive state with alcohol. So it's not actually a stimulant, but a depressant.
Can I ask a question?
Would be really appreciated.
This is Betty.
Hi, Betty.
I would like to know, yes, fine, thank you. I would like to know where to place the line between enabling, supporting, for instance, the patient maybe withdrawing and in need of help, when should I know to turn into enabling? I kind of see a thin line between supporting and enabling. So I would really like to know what would I call, when would I say it looks I've crossed the supportive line, I'm now enabling the client. Thank you.
Okay, this is a good question. If you have a patient in front of you who is withdrawing from alcohol or from heroin, enabling would be if you go to the street, buy heroin and give it to the person. That would be enabling. Supporting would be have an empathetic conversation and start therapeutic intervention because this person can be helped. That's what support means. The level of support, the intensity of support depends on two factors. How soon the person is in recovery. Is it very early recovery or the person is a little bit long in recovery, number one. And number two is the intensity of the symptoms. The more intense the symptoms are, the more intense will be your response. This is support. Enabling never serves therapeutic purpose. For you, in order to answer the question, if you feel both ways or you feel hesitant, what you're about to do or not to do, is it enabling or it's supporting? Ask yourself a question: what therapeutic purpose this will serve? And if you don't know the answer, don't do it.
I love that. That's really helpful.
Okay, maybe I'll give an example. My colleague just admitted a client into our facility. She is dependent on heroin, pentazocine. She's been injecting herself, and she was admitted in some hospital where they were just giving her each time she had withdrawal symptoms. So she came and she was withdrawing, and then she was crying. She was rolling on the floor. Just what to give her and the exact dosage, and yet she said she wanted to be detoxified. So the doctor said no, he would not give her that injection. He has some oral medication that he could give her, and she said oral medications don't work for her. They must give her the injection, and she was throwing tantrums, even as an adult. So, but the doctor insisted, say, if I give you that injection and the dosage is requested because you've been taking it for the past 10 days non-stop, I will just be enabling you, and I'm not really going to help you. So, but eventually with persuasion, she was able to take the oral medication, which we started, as a means of detoxifying her. And for 2 days now, she has been calm, and she's no longer in pain, and she's no longer coughing or having some diarrhea or whatever. And she feels good about it. But in the previous hospital, she had been blackmailing the doctors into giving her injections, the same dosage of what she was taking, and yet she said she wanted to be detoxified. So they were necessarily enabling her. But now she now knows that, of course, you can detoxify her without necessarily giving her what she was taking, and then get her in a better shape, to go into treatment.
Betty, this was a very good question. Did we answer your question, or you still have questions? Betty, unmute yourself.
Can I say something briefly?
Of course.
I think I've had a similar experience, but I would quickly say that one would need to know the difference between sympathetic and empathetic.
Okay.
Yeah,
Good
people
question.
starting recover. Yeah, people that are starting recovery many times they look for sympathy. They will come up with any reason they will appear needy, and they feel they need help from you, and they can come up with any excuse to let you feel sorry for them, to the extent give them drug they have been using. So by doing that, we are not helping them. We are just destroying them actually. So we need to know the line between being sympathetic and empathetic. Saying no when we are actually helping.
Okay.
I agree. The sympathy empathy line in my mind is very important too, and goes to exactly what Igor was saying. Because for one thing, when you get into sympathy, then it's like you're better than the person. Like I'm looking down, oh, you poor baby, and we put them in a position where they can't help themselves. As opposed to empathy, I've been in pain. I can relate to the fact that you're in pain. What can we do about it? And so I really love Igor's idea of just asking them, what's the therapeutic value? When you're sympathizing with someone, you're not thinking about a therapeutic response. In a lot of ways, you're often like, how do I make myself feel better? I feel bad that this person is suffering. When you're empathizing, then it's like, okay, well, this person's in pain. That may be something they're going to have to go through or experience. How can I support them or help them in a way that's therapeutic? Which may not always be giving them what they want, as a few people have mentioned.
Yep. Well, empathy, let's define, let's give definitions. Empathy is the ability to do two things. It's a clinical skill. By the way, it's a trainable skill. People are more empathetic than others, but it's a trainable skill. You can train people to be empathetic. Empathy is the ability to do two things. First is the ability to understand the source of the client's emotions, thoughts, or actions. In other words, you understand where the client is coming from. It has nothing to do with you agreeing or disagreeing with the person. You may be totally disagree and still be empathetic. So whether you agree or disagree has nothing to do with empathy. Empathy, number one skill, is the ability to understand where the client is coming from. And the second skill is to convey back accurately your understanding back to the client. I understand where you're coming from. I understand what you're going through. And I'm here for you to help you. This is what empathy is. Empathy is not specific to addiction medicine. Empathy is not specific to anything. Empathy is specific for any kind of meaningful human relationship. In other words, helpful way to think about empathy is like gas, the benzene, the petrol in your car. The petrol in your car does not define where are you going, whom are you going with, when are you going to stop for a cup of coffee. The petrol in your car does not define any of these things, but you are not going anywhere without it. You got it? That's what empathy is. No matter what you want to do, you cannot do it unless you have an empathetic attitude toward the patient. And once again, empathy has nothing to do with agreeing with the patient. You may totally disagree and still be empathetic. Sympathy is exactly the attempt to agree with the patient, to make the patient feel better, or at least to pretend that you are making the patient feel better. And typically, sympathy is what Kerry said is accurate. If the patient is crying because the opioid withdrawal hurts joints and the patient is experiencing a lot of pain, if you sit down with the patient and start crying with him or her, that doesn't help much. If you start telling your story, oh, come on, I've been through this before and I survived, so you will survive as well, it doesn't help much either. This is what sympathy is. Sympathy is a normal human impulse. But because you're professionals, you cannot act on your impulses. You need to act based on your clinical skills, and that's what we are trying to do. Does that answer the question? Ezra, did I answer your question? Did we answer your question, actually?
Well, the question was not mine. I just contributed as well.
Oh, okay. Okay.
Thank you. Looks like Faraday has a question or has their hand up. Go for it.
Can I ask something or comment?
Yes, please.
I had a question. We've had group discussions also, virtual group discussions, and one of the questions that came was, what is the relevance of this to me? So we have people from different backgrounds. Some of them may be hearing what may appear complicated scientific terms and approach of things. And someone may be asking, how relevant is this particular module to me? Maybe it is not mentioned, but it came through the group discussions. So assuming we had counselors, counseling psychologists, for example, and they won't be doing treatment, but they would be doing case management at one point or something similar. How would this be relevant to them so that they don't have to jump out and say, okay, I don't need this since I will not be in a rehab treating people?
All right. Can I say something, Kerry, about it? Just bear with me. Let me give you an example how relevant it is for counseling psychologists or for anyone. Actually, there are two things I want to say. One, if you only want to know what to do, that would be easy. You probably don't need this. But there are many people who know what to do. Even my well-trained dog, in most cases, knows what to do. The difference between professionals and non-professionals is that professionals know why. Not just what to do, but why. So this is one reason. And let me give you an example that might be helpful for your understanding. Imagine you have a significant number of people with the history of amphetamine use. One of the typical, almost 100% of patients with the history of amphetamine use, even if they are in recovery for quite some time, the longest lasting symptom is the sleep inversion. These are people who are very sleepy during the day and they cannot sleep during the night. This is a very debilitating symptom, and this symptom can last for months, sometimes years, after they stopped using amphetamines. The reason why people experience this system is because of the specific damage that amphetamine-type substances cause to primarily serotonin brain neurotransmission, not dopamine, serotonin. And unfortunately, we don't have evidence so far. We do not have evidence that these damages are reversible. So we don't know. It doesn't seem that way. Okay? I'm just telling you some fundamental neurophysiology. Neurophysiological example. Amphetamines damage serotonin system. The serotonin system working on some parts of the mesolimbic structures actually is responsible for your sleep pattern. In people with the disruption of this system, they will have hard time sleeping during the night, and they will be very sleepy during the first half of the day. Okay? Now, you will ask me, what relevance does it have if I'm a clinical counseling psychologist? And here is the relevance. If you have a large number of people with the history of amphetamine use, do not schedule appointments 9 o'clock in the morning. Change your business hours. If you're a director of a treatment program, open the program at 2 p.m. and keep it open until 10 p.m. This is the time when these people will be most active. And they will be the most effective and attentive. This is an example why fundamentals of brain physiology and the way different substances actually affect could be very helpful for your business and administrative decision making, including if you're a case manager and you have a patient with a history of amphetamine use and you need to do a serious meeting, well, don't schedule it at 8, 9, 10 in the morning. Schedule it at 3 p.m. This is just an example why, what is the relevance of this course to people who are not physicians. There's quite a lot of relevance.
Yes, please, I may add, Professor Igwe, Vice President as an American, but me, I'm talking as a Nigerian from the South Central part of this world. This course is relevant for everybody in the field of addiction. Because in my environment, before the UNODC came with their treatment program and Colombo plan came with theirs, everybody was doing their own thing based on their own professional training, and there was no coordination, no standardization, and the regulation of was very poor. Everybody would go and set up whatever they were doing, and they were antagonizing each other, doing all sort of funny things, complicating issues for clients, and even with limited knowledge, they assumed they knew so much. But when we started the treatment and then the Colombo plan came, it helped to standardize the work, and then it gave them a broader picture of what addiction is all about. So they know where they fit in, they know what is happening, they know how to refer, they know where to keep to their own area of expertise, and they know where they can network with other people, and then they can refer. And when people come for psycho education, they can actually give them good information about what is happening to them. And that has helped to standardize the work. It has helped us to network, and it has helped to train many more people. In fact, even help people to acquire skills that hitherto they never had. And this training, as far as I am concerned, is good for everybody who claims he's doing anything addiction. Initially, when we started, some people say, well, I don't want to be part of it. But when they now discover that clients are not going to them anymore, and each time they call, for instance, maybe in a forum, in a public forum, to discuss anything to do with addiction, or on print media, or you write something, or maybe on the television or radio programs, and then they put a panel to discuss, they discovered that they were so deficient that they couldn't really contribute much, and that made them, motivated them to come and join us in the training. And since we started this training, there's been a lot of coordination, a lot of networking, and then we find that we're giving better services to clients, and many more people actually are coming out. And in fact, it's helping us, to reduce the stigma as well with this field of addiction. And many more people are coming. So for me personally, working in this kind of environment, in fact, I have a lot of clergymen who come, who are doing like just biblical counseling for people who have using drugs. And they have come to take this Colombo course and say this program has actually enriched them, as making them more,
Something is happening here.
Oh, did we lose Moses for a minute there?
Refer them to the appropriate place. Thank you.
Thank
Okay.
you. Gladys made a comment in the chat. Gladys, would you be willing to unmute and tell us your contribution on the relevance of the course for counseling psychologists? I don't know if it's a issue with, if it's the connectivity issue or. Okay, so I'll move on. Someone else has a question. Does addiction to a psychoactive substance take over or reduce the need for activities that were previously pleasurable? Great question. If yes, what's the mechanism through which it happens?
I'd like to handle it.
Either of you go for it. Moses, you want to start?
Okay. Well, we know that for addiction to take place, for you to get to the stage of addiction, there's a reward pathway. Rewards any pleasurable activity, and then makes you to repeat such action because you enjoy doing it. And we know that dopamine is a key neurotransmitter in the reward pathway, and different substances, stimulate the reward pathway, to different degrees. Now, when an individual becomes addicted to a substance, the tendency is that the individual wants to repeat that action, and that means taking in that substance. And as much as you keep taking that substance, your attention, your concentration, and most of your life is focused on how to get this substance, enjoy it, and then abolish any withdrawal symptom that will come as a result of taking the substance. So if it's a very expensive one, you find that all your money is channeled and all activities are channeled towards getting the substance. So by so doing, you neglect other spheres of your social life. In fact, it may even be a family, it may be your educational pursuit, or even your professional work, whatever. You find that you prioritize the substance over every other thing that you do. So you spend your money, your time, your energy, and your passion on getting the substance. So gradually, all other activities are actually neglected, and it's because the addictive substance stimulates your reward system much more than the natural, pleasurable activities. For instance, food. Since they stimulate it much more than all those other natural ways of stimulating the reward pathway, you now spend much more time and energy and money to get this drug. And that means that you neglect all the other aspects. And that's how it comes about. Because if by the time you get addicted, you're even afraid of the withdrawal symptoms, even if you realize family or to my I'm not paying my bills, I'm not doing anything, but that you want to stop and attend to them. The withdrawal symptoms policy don't allow you to go there, and you're afraid of then you go back take the substance. So eventually you neglect other alternative ways of getting pleasure and other pleasurable activities. That's how it comes about.
Do you see the slide I just put here?
Yeah.
Okay. All of the psychoactive substances, all of them, affect this part
Yes,
of the brain.
we did.
All of the substances affect this part of the brain, right in the middle. We call them ventral tegmental areas or mesolimbic system or whatever you want to call them, it doesn't matter, as long as you know that this is the part of the brain. All of the substances, one way or another, affect this portion of the brain. Let me make it even fancier for you right here. Okay. The thing is that this part of the brain stimulates the impulses going to the frontal cortex right here. And this is the part of the brain that is responsible for decision making and good judgment. When people use substances, over time, I just want to show you one more slide. Over time, the impulses generated here in this part of the brain from normal pleasurable activities like playing sports, reading books, being in love, driving a car, or taking care of your horse, or whatever else, all of these normal pleasurable activities the pleasure will disappear because the drugs, by the way they produce the impulses here, will actually force the frontal cortex to forget everything else. And the only pleasurable activity that will remain, that will result in dopamine release and experiencing reward, will be the drug. This is people with chronic exposure to drugs, with developed dependence, will have a very, very difficult time experiencing pleasure from anything else other than the drugs. And by the way, this is the reason why when we treat people, and we know that actually in this case the drug is much more than just a chemical. People who develop dependence, the drug is their friend, their lover, their employer, their husband, their relatives, and there's something that gives pleasure. So when you do treatment, you better be prepared to give something instead. Just don't take it away.
Excellent. So Gladys and I have been messaging, and she's going to try to express some comments now, I think.
Okay. But this is a very good question. And by the way, if you, while we are waiting, in the DSM-5 and the ICD-11, these are two classifications and substance use disorder chapters. Actually, one of the diagnostic criteria for severe substance use disorder is people give up on other important social activities. This is not just a symptom, this is one of the major diagnostic criteria in both classifications.
A quick one. It's a question. Why do people continue to use drugs despite harmful consequences?
Well, because they have a disease. Why do people with diabetes continue having blood sugar despite the consequences and despite the fact that they're keeping on a diet and taking medication? Well, because they have a disease. And there are some genetic vulnerabilities, there are some behavioral vulnerabilities. And people continue using drugs, people with developed dependence, and actually, in fact, the continuation of drug use, despite obvious negative effects, is one of the key symptoms of developed dependence. Actually, the most important criteria for developed dependence are not tolerance or withdrawal. No. The most important diagnostic criteria is loss of control. And this is, substance use disorders are not the only, not unique conditions with loss of control being the key criteria. For instance, obsessive compulsive disorders, the key criteria is loss of control. The Tourette syndrome, a neurological condition, people cannot control some spontaneous movements. Okay, so the substance use disorders are not unique with this criteria of loss of control. But the continuation of substance use in people with developed dependence is outside of their voluntary control. They cannot just say stop and keep stop for any length of time. They can't do it. This is why they need treatment. If you have a patient who is able to say, stop, I'm quitting drinking, and then stop drinking and not drink for years, then this is a good news because this patient doesn't need you, because the patient doesn't need therapy. That's all.
Thank you.
And sometimes some of them actually get to a point where they want to stop. They realize that they're doing harm to themselves, but they're not able. And sometimes even when they attempt, in fact, for some of them, the withdrawal symptoms are, what drive them back to continue taking the substance. For instance, those who are on opioids or those of them who actually withdraw, have severe withdrawal symptoms from alcohol. And they will come and say, I've tried to stop, but I'm afraid each time I attempt, this is what I feel and I'm scared. So, and some of them don't actually know that they can be helped. Training and knowledge, some of them have actually been helped and they are doing their best, in their journey to recovery.
And one more thing, going back to physiology. This is why it's so important to know it. And this is about the relevance of this course. In the brain, there is a device right here. We call it amygdala, and I'm sure you have heard about it. Well, amygdala is the brain responsible for feeling anxiety and tension. When you are stressed or you're under threat, that's amygdala will activate and will let you know that you better do something about the situation. Well, the more active is the amygdala, the more anxiety people will experience. Okay? Well, all of the psychoactive substances actually reduce the activity of the amygdala. Consequently, when people try to stop using, the amygdala will get very active. And I just told you what happens when amygdala is very active. You will be very, very anxious. And this is the reason why almost in 100% of your patients, the first couple of days in recovery, you see a lot of anxiety. They are not happy. They're not happy because of maybe some of the psychosocial reasons, because they're sober for the first time in 20 years and they see that the life is in a deep doo-doo, that nobody is happy. But one of the physiological reasons why people feel anxious is because of the activation of amygdala. In this case, when amygdala is active and people are very tense and very anxious, this is one of the most common reasons why they will start using right away, because this sensation is unbearable. It's really difficult to deal with. And this is the most common reason for relapse and continuation of drug use. So it's not just, and actually this has nothing to do with bad habit or lacking willpower or being insane or being criminal. None of this nonsense, folks. It's by far deeper and much more serious than any of the nonsense I just mentioned. It's a serious and profound neurophysiological brain disease. The good news, the recovery and treatment is possible. The bad news, it's a serious condition and needs serious treatment.
Mm-hmm. I knew if I brought, my doctor friend, that the big terms like deep doo-doo, their lives are in deep doo-doo, would be presented. Okay. Other questions or comments?
Yes, I would like to ask one. This is Betty
Please.
again.
Betty again.
Yes. So in Africa, people are highly spiritual. There are spiritual connotations to different aspects of life. It's common to find clients struggling with addiction, subjected to long periods of prayer, sometimes prayer with fasting. Sometimes they are taken through periods of exorcism, in a way to cast out the evil spirit addiction. And many times, addiction is also attributed to witchcraft, spell, and so on. And these are really strongly upheld. How best could we help our clients to understand the science of addiction, to understand that, it's not demons, it's not witchcraft, it's a disease? Thank you.
That's such a great question, Betty. Thank you. And thanks for the context. Has anyone had any good experience with that? Helping?
Well, maybe I go first, since I'm working I'm in Africa and I work in Africa. It's a similar thing in my own environment here, and but we have been having some engagement with a lot on the media and through outreaches. We reach out to different groups, and then eventually, they invited me to talk to them about all this addiction and that's mental health, whatever. I had to talk to them for 3 days running. All their master students who are doing psychology and biblical counseling started coming, developed interest, and then they started coming. And when we started this treatment combo plan, after the basic physiology and then the disease model of addiction, it helped them to come. And then many of them have been coming who don't even take courses in psychology and biblical counseling, but those of them who are really interested in counseling, particularly the young people, they came for this training, and that has helped them their congregation and also reaching out to others. And now that concept of demon and then making their class feel very guilty, and demoralized that they are very bad people, they are outcasts, so on and so forth, is no longer there, and they now actually see how they can help them. And I'm getting more referrals from clergymen now and people who are in the religious circle who are also praying and fasting for them, sending these clients for some of these things. Sometimes they say, okay, this client cannot go through the whole process of treatment like an inpatient thing. He doesn't have the resources, but can you help us detoxify him? then the rest we can continue. And because of the environment we work in, we accept such clients. Some of them would mention that we justify them, and then when they're stable, then they continue with them. And that has been a good working relationship, and it's really helping, to I'm excited about what addiction is all about, and we're getting more. So it's helping clarify this issue of human possession, some realizing this addiction as a more failure instead of it is brain. That's what is happening in my environment now.
Well, if I may add to what Moses just said, spirituality in some societies, in some communities, is actually a major factor. And it's a major cultural issue. In general, whatever it takes, if it helps and it doesn't hurt, use it. If you have some reasons to believe that this particular approach could be helpful to people, and it doesn't cause any trouble, or at least risk-benefit ratio is acceptable, do it. Why not?
Obviously we always want to be respectful. Yep. Obviously we always want to be respectful of anyone's spiritual beliefs or cultural, any type of beliefs. And as Igor said, if there's a way to use, that could be a type of recovery capital if someone has a strong spirituality, a strong support system in a church or things like that. But as you said, as you asked, Betty, then it's how do you switch the understanding of it to a disease model, though. So, but maybe you can utilize both. Explaining that we're understanding more and more about the brain now. I'm just explaining it as I like to talk to my clients just like I'm just learning this and figuring this out too. I'm just putting us on an equal playing field.
Can I say something about that quickly?
Please.
Yeah, I'm working with one of the mainstream churches in Uganda, and I have made one of the strategy for prevention, drug misuse prevention among youth, is to train the leaders and do advocacy. And the majority of the leaders we've trained or training are religious leaders who are in a position of leadership that can influence policy. That church has over 4 million, 4 million. Gorek, what is the population of Uganda?
I think that's a really great point and a really great idea. You can get leadership on board. Yeah.
Yes, the church alone, one church has 40%. 40% of the population of Uganda is for that. 40% of the population of Uganda. So we are training the religious leaders, and you are shocked at when you do the assessment before the training and after the training. The attitude before the training is addiction is a behavioral problem. It's for bad people, and sometimes that wouldn't be allowed in places of worship. And then that's the kind of we need to start with. To train leaders, give them facts. We must have data. We must be well equipped, so that once we have a buy-in, we can influence decision making up to policy level. We are just crawling in Uganda about these things. So Nigeria, South Africa, Kenya, you are ahead of us, but we have started crawling. So we thank you for this support. The people that are in this group, all of them are professionals. They have passion for this, and we have been discussing all this about advocacy. after getting this knowledge, what do we do? Apart from our practice, we have to plan some kind of association or getting together, like Moses was. Think about standardization. Think about expanding, professionalization. We are already negotiating between each other how many are going to do the ICAP 1 exam. We have discussed the career path of ICAP 1 up to 3 and then recovery support. So people now have a clear picture of where we are heading to after this training and beyond. But partly Moses, what we thank you very much.
We're really honored at ICU-DDR to be part of that process, and we can definitely.
Maybe just to from my own experience, I am also a very spiritual person. And they have their own, prejudices, and they have, their own belief system. And some of them, in fact, they're only coming there to challenge you. But I don't oppose them. I say, this is what science has taught us. This is what we have seen, and this is how much we have known. Perhaps, if it's demonic, maybe the demons interfere with the brain in this way, and then the person and makes the brain sick. So, in this way, and then we understand it, then we can counter it, perhaps by using drugs or whatever, and then we have studied to see how we can help, and collaborating with you as you pray. We can do this aspect, we can give medication, we can counsel, we can do things to get the person, whole. So it's a form of collaboration, not say, no, what you are doing is wrong, not. So, and in some of the treatment states, we have clergymen who pray for them and take care of the spiritual aspect of it. And this collaboration has actually helped us, to work together. But if you come from the way that, no, it's a disease model, there's nothing spiritual about it, they will run away because you are touching a very sensitive aspect of their life. And I know in my environment, they will kick against you. But, well, I say it, this is what we know. Perhaps the devil or the demons tamper with the brain in this way, and then they are coming down with it this way. And then when you do this, you can also effect a change, and you can also help through prayers. Then we collaborate, and it's been working better for us in Nigeria.
Thank you. So one of the questions.
Forgive me. I've been to Nigeria several times, Moses, and I think we met there when I was there in Nigeria, in Abuja. No?
I never met you, sir.
Okay, but
I never met you, Prof.
We
met in Kenya. We met in Kenya.
We met in Kenya, but prior to Kenya, I've been to Nigeria a couple of times, and I met a lot of people. I don't remember all of them, and it's a very, very interesting place. But I also communicated with, speaking about the education for leaders. When I was with the UN, there was a gentleman in Uganda who was quite effective in doing that. His name was David Basangwa. Is he still around?
He is. Yes, he is. Dr. Basangwa is we are still in touch. We work together on a number of projects.
Okay. Please say hi to him, because he knows me and I know him. And I remember he did some very good quality work educating leaders and decision makers in Uganda. He was quite effective. I don't know if he's still doing that, but this is something for you to consider. Just one comment. Disease model of addiction is one of the models. Like any other model, it has some pluses and it's some limitations. The model, the conceptual framework, and the most science-driven, evidence-driven model that we have so far is the biopsychosocial model. The disease model tends to medicalize the problem to a very large extent. Actually, the disease model was conceptually formed in the 60s and 1960s in response to all these statements that this is a bad habit, madness, craziness, criminality, lack of willpower, all this nonsense. So that was actually the response to these statements, building a disease model. We need to be very careful not to overly medicalize the issue, because there are quite a lot of behavioral contributions, environmental contributions, something that we need to be mindful. So I would suggest you to, in your conversations, particularly with decision makers, make a reference and refer them to the biopsychosocial model as a combination of physiological vulnerabilities, individual psychological vulnerabilities, risk factors in the environment, the combination of all of these things. This is what makes the whole problem so problematic. Let me show you something that if right here, just give me a second, that might be helpful for your understanding. Why? Do you see it?
Yeah.
This is a range of biological problems or biological vulnerabilities, mostly genetic. These are some of the psychological vulnerabilities, individual. And these are some of the factors from the environment. So when you have these three areas of dysfunction overlapping, this is where the actual person with the problem is going to be. It's not just the genetics. It's not just the psychology, neither just the environment. It's a combination of these three major things. Does that make sense?
Yes, it does. Yeah, it does.
Okay.
Thank you very much. I let me talk about my experience about this biopsychosocial. I was at a radio program in my own city, and then I talked about the biopsychosocial model, how genetics and environment and the social factors contribute to addiction. Or but after that, one of the students, the university, met me some days later and said that the teacher told them there was nothing like genetics, that it's all social learning. We are trying to deceive them into believing that genetics play a role, that these things are learned behavior, and genetics doesn't have a role to play in it. And then some months later, in fact, a professor of one of the disciplines, while we were doing Colombo training, told us that he didn't believe in anything genetics. That genetics, he doubted the contribution of genetics, to this biopsychosocial model we're talking about. We said, well, this is the evidence. We can bring our own evidence, but it became a heated debate. He said he never believed in it. And some of them taught their students that this genetic thing is just because we want to bring disease models, so on and so forth, into it to convince people, but genetics didn't play a role. So some people, no matter what you do, will be resistant to what you're trying to say. But a few of the students that were taught who came to our own facility and met us during one of the clinical rounds and were discussing clients, came later to say, we believe what we plays a major role. We believe in it more than what our lecturer taught us. But for exam purposes, we can't tell him that we don't believe in genetics. But from your explanation, what we have seen clinically, we want to believe. This perspective and it got how we settle it.
All right, so one question here, interesting, is we learn that sometimes addiction permanently alters the brain's physiology so much that even therapy cannot rectify it. What exactly is the alteration?
Ego can add it from his own expertise. The alteration is such, we talk about neurotransmitters and the psychoactive substances acting through neurotransmitters to affect whatever symptoms we in the but the body to maintain an equilibrium. So when you come with an exogenous substance that is not endogenous to the body, and you try to stimulate this reward pathway, and then this surges of adjust. It's an unnatural thing to the brain, so it disturbs the equilibrium, and then the brain tries to adjust. When there are surges to the system, the brain says, okay, this substance has to be able to effect. Now the brain cannot reduce the receptors. So the brain reduces the receptors, in the brain, so that there wouldn't be so much receptors for the substance to actually act, and and to be able to exert the effect on the individual, and so many other things. So that with with time, you find out that this adjustment almost becomes like something that is prolonged, and the brain doesn't react naturally anymore to natural stimuli, only to the substance. It adjusts only to react to the substance that the individual has been taking. So when you find that in the
Something happened.
counseling, that the have to, it might respond to other form of agents to restore the equilibrium, and then to make up for the the reduction in the receptors that the brain was used to. So these are the problems. So that even when you do psychosocial therapy, some need some pharmacological and actually result in them, because the brain has adjusted to this unnatural way of stimulating it. Circle, you combine it with something to get a patient brain.
Well, if I may, I want to address the app, because this is the only thing I've heard before my connection broke up. You said that some of
and then the receptors.
You said that some of your professors don't believe in genetic involvement in genetics. Is this accurate?
No, okay. Maybe if I tell you why is that going back.
I don't want to interrupt Moses, but it seems like he's having trouble. So what we're actually talking about, Igor.
Refuted that claim that in one of the in Nigeria,
well, sometimes professors need to be educated as well. Being a professor is not a guarantee of current knowledge. At the state of the science in 2020, considering the amount of genetic research that we have generated in the last 30 years, it is very hard to to refuse the amount of evidence. It would be very difficult. Earth, if you look at the Earth, if you look through the window, Earth looks flat. It does. But we know from the space exploration that our planet is round, but it certainly doesn't look rounded to me when I look through the window. That's the difference between my perception and what we know from the science. And I know that the Earth is round because I trust science. This is pretty similar. It would be really difficult to deny the genetic involvement. However, there is a however here, and I really want to address it. In the entire medical field, there are lots of genetic conditions or conditions that have some genetic involvement. There are essentially two types of genetic conditions. One are so-called genetically determined conditions. Genetically determined means if you are so unlucky that you got two sets of pathological genes from both biological parents, you will develop this condition and there is nothing much I can do about it. And this has nothing to do with your lifestyle, education, nutrition, exercise. Example, cystic fibrosis, a lung disease. It's a clearly genetically determined condition. Huntington disease, a neurological.
In Africa.
Yes, Huntington disease, a neurological condition, clearly genetically determined. So you got this pathological combination of the genes. Sorry, you're out of luck. That's what happened. And this has nothing to do with anything else. The good news here, alcohol and substance use disorders are not genetically determined. There's another type of genetically influenced conditions. We call them genetically influenced. And genetically influenced means if you have some genetic vulnerabilities to develop a condition, if you have a family history of it, you are more at risk. You are more at risk to develop it. Example, hypertension, diabetes, breast cancer in women particularly very genetically influenced, and some other forms of disease. It doesn't mean that you will develop it. It means that you are at the greater risk to develop this condition because of the genetic vulnerabilities. If you are very genetically vulnerable to develop alcohol use disorder, and because of this knowledge, you decided not to drink, you will never develop alcoholism. Even though you are genetically vulnerable. That's exactly the reason why you made a smart decision to stay away from alcohol, because you know you're genetically vulnerable. If you have a family history of diabetes, it would be a very smart decision to measure your blood sugar, to keep on a diet, to control your body weight, and to check with your doctor more often than other people. You see, there are quite a lot of things that you can do to minimize the risk, but the risk is there. You can reduce it. So substance use disorders are, without questions, are genetically influenced. I will tell you even more. We know exactly what part of the genome is involved in most of these conditions, but they are not genetically determined. Does that make sense?
Makes a lot of sense. Only that some people are just amenable to knowledge or learning. So if a professor will say all sorts of things and all the evidence, what do you do?
Well, you know what what you don't want to do is to start arguing with the professor. But what you can do not accept everything that professors say as the final truth. Educate yourself. Educate
Not
yourself.
at all.
Look for the evidence now with the internet. There are so many data available and so many good quality literature available to people. Educate yourself, get your curiosity going, open the manuals, open the books, open the libraries, and make your own judgment. Professors sometimes say stupid things. I'm professor, but I'm not immune against mistakes.
I know for sure that you've said stupid things.
There was another question that was asked, which was, is it that some other people will not just respond to psychotherapy or psychotherapy alone without medication? And so that was what I was trying to ask before you came in. So okay, I said that.
Ask your question again. Why some people need medication?
We not just respond to psychosocial therapy alone. Why is that psychosocial therapy alone cannot take care of them without drugs? So I was just trying to explain part of it when I said because the drugs there are a lot of surges in stimulation of this reward pathway, and then a lot of neurotransmitters, coming in because of the drug intake, which is unnatural to the brain, and the brain is used to maintaining some form of equilibrium, and this surges come in, and then the brain tries to contend with this unnatural phenomenon, and by reducing either the receptors or even the neurotransmitters. So if it goes on for a long time, then the brain reduces in a way to take care of itself, reduces the amount of receptors so that it will cope with all this surge of substances taken. And then when it becomes prolonged, establishing of the brain or even the amount. And that's why even when the individual, maybe is detoxified and stops taking medication, the brain doesn't just respond to any other thing like before. It's not responsive again to other like before, because bombarded by some of these exogenous substances and other substances. And that's why for some people, they will always need this pharmacotherapy in addition to psychotherapy or psychosocial intervention to help them, to stay afloat. For some, yes, if you do counseling or psychotherapy or psychosocial treatment, for them it will be all right. But for some individuals, they will still need some form of pharmacotherapy to remain stable. So maybe you can add from there, Professor Igor.
Well, we have medications only for people with alcohol use disorder, opioid use disorder, and nicotine use disorder. We do not have medication for anything else. These are the only 3 types of substance use disorders that we do have quite effective medications. Medication alone is not going to help. Exactly the same way like in patients with diabetes, even if you have a patient with diabetes who is responsive to insulin 100%, and the blood sugar should be under control and everything should be fine, but if the patient does not keep on diet, eats cakes and cookies every night, 145 kilograms, and does not exercise, the patient is going to die anyway. Okay, so the medication could be helpful, and definitely in this case could be very helpful, but the medication alone is not going to solve anything. Medication is just a component of treatment. And for most of the substance use disorders, we do not have medications to begin with. So the only thing we have is different types of psychosocial interventions. The good news is that most of the psychosocial interventions, if delivered correctly, are very effective.
Something
And then
quickly?
maybe to add again, you have to also distinguish between those who have just drug problems and those who have depressed or have some other mental health disorders, and they're taking the drugs, along. So even if you deal with the drug problem and you don't tackle the fundamental mental health disorder, for instance, maybe schizophrenia or whatever, they might still go back taking this drug because they think the drug is helping them in one way or the other. So sometimes it's not just pure drug problem, but there might be dual disorders. So we have to also understand, because in my own place, they can say, oh, he only takes drugs. There's no problem, he only takes drugs. But when you are discover that the patient has been chronically depressed or has even been schizophrenic or has even a bipolar, and then you're not using medication, and they think that it is the drug that is the problem. But they know that there's a fundamental bipolar, affects organ underneath that, making the client also to take these drugs each time he relapses or whatever. So you have to also understand that sometimes there will be dual diagnosis, and the client will need medication, even if he's treated for the drugs, but he has to treat the fundamental mental health disorder.
I just wanted to say that my colleagues, not every person that takes a journey of recovery goes through medical treatment.
Yeah.
We have Narcotics Anonymous, we have Alcoholics Anonymous, we have people that walk into these groups and start a journey of recovery with people that support them, and they live a life of recovery, and they have never taken any medication. So I think we also need to understand when should medication be administered. Because in some of the rehabs in Uganda, every person that gets to the rehab, they are sent straight for treatment. Every person that reports go through some kind of detoxification. So should every person that walks into a rehab, but even those that have been taken there by force, should everyone be subject to medication?
No. No. Well, there are two things in your question. One is the detoxification. Detoxification is not a treatment model. Detoxification has nothing to do with treatment. The only reason the only reason to do detox is to make sure that the patient is alive, because it would be very difficult to work with the patient if the patient is dead. So that's the only reason for detox. Most people don't need detox. Some people do. And as I said at the beginning, particularly people who are withdrawing from depressants, because this is a life-threatening condition, they might need some medical attention and they do need detox or initial treatment. But detox by itself is not a treatment at all. It's just a first step to get something going. So it's number one. Number two, not every patient needs medication treatment either. I'm talking about the long-term medication. Not every patient with alcohol use disorder will need a camprosate or naltrexone for alcohol treatment. Not every patient with opioid use disorder will need methadone or buprenorphine. It's the matter of your clinical judgment and clinical assessment. Exactly like not every patient with diabetes will need insulin. Some patients can be well managed on diet and exercise before any medication can be considered. Well, that's pretty much the same logic here. Not everybody needs medication. And again, it's like in any other medical field, there is no difference here. Your judgment about the need or lack of the need for medication is based on normal medical logic. You do the assessment, and the assessment will tell you whether you need to do medication. In general, if you have somebody dependent with severe opioid dependence, heroin dependence, initial medication could really open the door for a very good. That would be something I would definitely consider doing. If somebody with alcohol use disorder and you have naltrexone or a camprosate or any other medication with good evidence of effectiveness, and the person is incapable of maintaining any length of remission, that's what I would consider definitely doing. It might help. Again, it's all the matter of clinical assessment.
Another one, a quick one.
Gladys just said that I think assessment is needed before sending people for detox. Yes, she's absolutely right.
Just a quick one. Having said that, how research has shown that 1% of the people that get addicted, or a certain percentage of people that leave rehab relapse within the first 12 months. That is my first question. Why that? Then another question. Somebody asked about alteration, permanent alteration that cannot be reversed. How come a person that has been sober for 30 years, when this person relapses, they're affected like they had never been sober at all?
Yeah, that's a good question. Well, let's start with the second one. When people develop dependence, one of the things, or there are a couple of things that happen to the brain. One of them is the increase the number of receptors on a square foot of the brain surface. There will be a greater number of receptors with lower sensitivity. The brain will decrease the sensitivity and will increase the amount of receptors. When people are getting into remission, particularly long-term recovery, these newly built receptors don't disappear. They will stay there. They don't go anywhere. They're just sleeping. Their sensitivity went down. They're sleeping. They're calm. They're not causing any trouble, but they're waiting for their time. And the time is 25 years in recovery. Somebody decides, I'm fine. I've not been drinking for 25 years. I can have a sip of whiskey. Well, that's exactly what will happen. All of these receptors that do exist, they will wake up right away, and they will have a good party, and then they will give you a lot of trouble. Then people go right back 25 years. This is the reason why people with developed substance use disorder, unfortunately, will never be able to drink or use drugs in a controlled way. Never. If you look at the data, there are studies. Is it possible for somebody with alcohol use disorder to get on controlled drinking? Most of the data suggests no.
And that where you said everybody in Uganda going to rehab, gets medication. I don't know about Uganda, but I know that here I run a treatment facility. In fact, most of the clients that come with complications. They don't bring people who say, okay, I think I need help and I want to seek help. No, they only bring people who come with complicated problems. They are withdrawing from alcohol. Most times they are convulsing, and it's after the convulsion that they rush them to the rehab. And then sometimes perhaps they are involved in road traffic accidents, and then they were alcohol dependent. In fact, the physician may not even, or the surgeon may not even have thought of the alcohol, but the man starts convulsing in the surgery, and I'm wondering, maybe history, whatever. I said, did you take any history about alcohol dependence, alcohol use? No. And then you take a history, and the man has been alcohol dependent. But he's been involved in a lot of accidents, and nobody took the history, and it's not convulsing because having severe withdrawal. So when you get patients like that, obviously you will need to take medication. And as Professor Igor said, there are some who have been alcohol use disorders, and in my own place, resource constraints. Most of the treatment is psychosocial after your initial detoxification. So somebody say, I want to abstain, but it's difficult, the craving, I can cope. But can you give me something to maybe reduce the craving, whatever? Yes, you can use naltrexone. Since they're highly motivated and they want to stop, that helps them for some time before they stay off. And then those who use opioids, in my own environment, where we have methadone, the government has not even allowed us to use the methadone. For some sentiments of cultural, and religious beliefs, they believe that we are indulging them in the use of substances. They have, because of the UNODC training, they have brought in methadone, but the logistics to use the methadone, they don't want to give us. And it's then maybe even getting expired. So you just detoxify and then continue with the psychosocial treatment. So they don't use drugs. We use medication only when there are comorbid conditions or dual disorder, or when they come initially with complications. So you will see that those is a selective process. Those the rush to rehab have come either in a severely psychotic state, very aggressive and destructive. You cannot say you're going to talk to them at that stage. You must use drugs to calm them. So that's why sometimes people think that when they come to rehab, everybody use drugs. No. So most of the clients I have actually are referred use only psychosocial methods. So we cannot handle this one. This one it came with alcohol problem, but it's convulsing. He's always going to breaking our rules. He's always going to drink. We cannot handle it. So they are the ones that refer. So you have to help detoxify some of them before you send them back to them for their treatment. So that's why some of them use drugs, not because we want to make them stay on drugs forever.
Let me give Carrie. Can I say something? Do we still have time?
Yes, we only have about 10 minutes, and Gladys has been trying to get in here. She's been messaging me, so
I see her questions. Actually, we are answering some of her questions.
Yes, good. Thank you.
Folks, all of you, I'm going to give you a hypothetical that might be helpful. Imagine you are a prime minister of a country X, and you just got a report, a reliable report, that shows you the numbers, accurate numbers, that only 20% of people with diabetes are getting treated in your country. And in this 20% of people in treatment, usually the treatment starts when their kidney already failed, they're blind because of the diabetes, and the legs are amputated. Okay? You got this report. So what are you going to do? I will tell you what I will do The first thing I will do, I will fire the Minister of Health right away. And the second thing I will do, I will invest a lot of effort in training and educating primary health care settings, how to detect the problem early, how to intervene early, and how to make sure that people will not develop severe complications of diabetes. That's a common sense. That's what we do all over the world. In addiction around the world, we woke up and we start treating people with advanced late stages addictive disorders with a lot of complications already in place. And then we are very disappointed why our treatment is not very effective. Well, the treatment is not very effective because it's similar to starting treating somebody with cancer, the stage 4. Missing all other previous phases, waiting until the person got to the stage 4, and now we're starting treatment, being very surprised why we are not very effective. That's exactly what happens in addiction medicine. We have 45 to 50% of the general population, people who do not have any problem with substances. And the only thing we need to do is to maintain it, to do some prevention, and they will be fine. We have approximately 35 to 40% of people in the general population who already have some difficulties with substances, but they will never come to see you. The difficulty is already there, but the severity is not there yet. They will definitely come to see a primary health doctor or school counselor, but they're not going to see a psychiatrist or addiction specialist. No. And there are approximately 8 to 10% of people with severe substance use disorders. And unfortunately, this is exactly the top of the pyramid that when we start doing treatment, being very surprised why these people don't necessarily respond well to treatment, because we wasted a lot of time. And we wasted a lot of time because we did not train our students and our primary healthcare staff in early detection, early recognition, and early intervention. And I'm not talking just about Africa. We are not very good in the United States as well, training our medical students, medical trainees, and young physicians. We are not doing a very good job. We are trying to do it better, but we're still far from being good. So this is why the idea about how to choose the right treatment and why treatment does not necessarily result in what you would like to see, a big part of it is because we wasted years and we started treatment when the person has already a lot of troubles.
And just to quickly add to what we have, in fact, you've just discovered what's happening in my own country. But you know, with all this data and whatever, there's a lot of stigma towards people with drugs. Especially, even you find that even rightfully, you know, they discriminate against anything to do with mental health, and worse when it comes to addiction. It's another thing. And it doesn't have anything to do with substance use or addiction. They keep dragging their feet. Just as I said, we have methadone for the substitution therapy, but they will never even give us the methadone to use. It's there in the store, and they're not giving it because they don't see why they should even spend so much on people who use drugs. Yet we have a lot of people dying from drugs and alcohol, and people also, you know, doing so many terrible things out there because they are on substances. But they don't see, they see that as very bad people who should not even, they shouldn't even waste their resources on bad people like that. They would rather go for other non-communicable disease that will take care of the people who are, you know, addicted to, you know, so it's a big problem for us here.
So we need to wrap up in the next few minutes, but I have another question. Why do people who are addicted stop the use of one drug and transfer to another?
Okay. Let me define addiction for you. Let me not define. Let me remind you the definition of addiction, the way it is defined by the DSM and Institute of Medicine. Let me just find it because I think it is critically important for our conversation. Just give me a second. Give me a sec. Okay, here it is. This is important. This is actually a very good question. Here it is. Addiction is a compulsive, meaning outside of your voluntary control, repetitive, meaning there is some pattern here, and maladaptive pattern of behavior that continues despite biological, psychological, and psychosocial problems. Please pay attention. There is no single word about drugs or alcohol. And I think that answers your question. Why people who are in recovery from alcohol actually may start using other drugs. Because the behavioral pattern, unless it has been changed through treatment, so a maladaptive pattern of behavior that continues despite obvious problems.
Can I ask a quick also? What about gambling and sex? I think there's something like process addictions. Does the brain affected in a same way like substances?
You will be surprised. Yes, in a very similar way. In a very similar way, not exactly identical, but in a very similar way. Correct.
And maybe if I quickly add, the question you asked that was asked earlier, why would they use one substance and leave it and go to the other? Yes, because the addictive potential of drug varies, and some of them can stimulate the reward pathway more than others. And for instance, somebody might be using a lower opioid. For instance, in my own environment, the one that's commonly used by everybody is tramadol, and then some people who have the money can use pentazocine. But after some time, they feel it's not working for them because they've developed tolerance. And because of the definition of addiction that Professor Ego gave, they go for a higher one that will give them what, they will get the same effect. Since this one is the lower one is not giving them the same effect anymore, they have developed tolerance, then they go for petidine. And for petidine, if it doesn't work after some time, then they move on to morphine. So it is just because of the definition of addiction and the tolerance they develop, they want to go to get the same effect. So it's common, and we see it very commonly in our place, in our environment.
Let me just address what Kenneth shared in the chat. There are actually herbal therapies that have been proved to be effective for therapy of the addictions. I have never seen any evidence to support it. So I don't know. What I do know, based on my understanding of the scientific literature, I have never seen any evidence of that. Because you said it's been proved to be effective, I would love to see real evidence that you are right. Maybe you're right. I just don't know.
Okay, well, I'm going to wrap it up. If you have more questions, we can have more discussion in the WhatsApp group or on the learning management system. I'm so grateful to you all for your participation, and thank you so much to our visiting doctors, our trainers. We will be seeing you again, and we can talk more in January. So happy holidays to everyone, and thanks again.
Here is my email. If you have questions, if you want to write to me directly, please do. And be safe and good luck. It was a pleasure working with you and seeing all of you.
Thank you so much.
Thank you, ICDR.
Thank you.